Tired of the conflicting advice in the world of health and wellness? Ready for clear, science-backed strategies to live a longer, healthier life? Welcome to the Duration Wellness Show. We focus on health and wellness education to help you become a better, more informed you. Wherever you are on your journey, we're here with you for the duration.
Well, welcome to the Duration Wellness Show. So excited to have you here. So this show is for basic medical awareness and health education. It's not intended as medical advice. And so excited for our guest today, Dr. Esmail, who is not only board certified in internal medicine, but also cardiology and is an associate professor. So she actually teaches our new cardiologist in fellowship, who is just amazing. And so we are basically here to talk about cardiovascular prevention and heart health. So excited. So excited for you to be on the show. Welcome. I know that was I know it was a little intro. I don't know if you want to do a little bit more.
Yeah, sure. So excited to be here. Anna and I actually did our training together at UF, and I stayed on for cardiology training and as faculty here. So I'm in year 6 of my faculty here as associate professor. Also in charge of the Echo Lab here, so medical director of the Echo Lab. We have a ApoB program that I'm involved in, as well as cardiac rehab and teaching the fellows. So a little bit of everything here, but prevention is really one of the big things that I'm interested in. And so I'm really excited to be here to talk to you guys about it.
Yeah, I can't wait. And I know it's something that I'm very passionate about too. You know, I think it's so much better if we can kind of stop, it's way better to prevent a heart attack than to have a heart attack and then treat it. Right. So It's just so important. So I think kind of getting into it, what would you say are like the biggest cardiovascular risk factors that you see patients coming into your clinic with?
Sure. So the big things really are hyperlipidemia, so elevated lipids, so elevated LDL, total cholesterol, triglycerides. High blood pressure is a big one. And a lot of people, they go a long time without knowing they have high blood pressure. And they do call it the silent killer because it really affects a lot of people. So blood pressure is another major risk factor. Other one that's really big is obesity. And now with these GLP-1s, we're trying to tackle that. And so obesity is another major risk factor because those fat cells release a lot of inflammation into the body. So those are the main ones. And then specifically for women too, preeclampsia, premature delivery, gestational diabetes, gestational hypertension. These are all major risk factors as well for coronary artery disease.
Which I think a lot of people don't realize that, when they're pregnant and because it's usually they kind of view it as a temporary diagnosis, right? Because you just had it during pregnancy. And so I think people don't realize a lot of times that like when you have these gestational diabetes and gestational hypertension, preeclampsia, that kind of sets them up that they're in that higher risk category for all of these, because it's kind of a warning sign that, that you're at higher risk for developing diabetes if you have gestational diabetes or a higher risk for developing hypertension and stuff. So I think a lot of people don't realize that is in that, in that category too.
Right. So I ask all of my patients when I'm seeing them in clinic, did you have any preeclampsia, any of these risk enhancing conditions? And then we can really get a good risk assessment for our patients.
Yeah. And what about like sleep apnea? Do you find that that's kind of related too, or not as much?
For a lot of other conditions, so it's all related. Sleep apnea definitely increases blood pressure, which in turn increases your coronary artery, risk. And then it also increases arrhythmias, so the heart rhythm issues. So they're all related. So that is part of our screening as well, and making sure that they do get a sleep study if they have the criteria that we're looking for.
Yeah. And then I know you said a lot of people don't know about their blood pressure. I find it so true. I'll have patients who come into the hospital and they're hospitalized and they're like, I don't have any medical issues. And you're like, your blood pressure is insane, but they never checked it, right? Even though it's like, you can go into grocery stores. A lot of them will have those like cuffs that you can use to check. And now it's so easy to get the over-the-counter cuffs, right, where you can just have it from home and monitor. And so people don't realize how important it is to be checking those. It's like so important.
Yeah. And even, when we do see them in clinic and if their blood pressures are elevated, we make sure we get some readings at home because they can have white coat hypertension. They're just stressed out about the visit and all anxious, or they went through a lot of traffic. So we do like to get those readings to the side of the clinic visit to just really confirm. But really, I think everybody should have a blood pressure cuff at home, especially if they have a diagnosis of high blood pressure.
Yeah. Yeah, I think it's very helpful. And then you were talking about lipids, which I think is kind of bringing up, the next question that I think people should be aware about, like how should patients think about their lipid profile for heart health? I think cholesterol screenings I think it's a good thing that they're becoming more common and people are being more aware that they need to know this, but how should people kind of like look at those and interpret them and all that?
Sure. So there's a few different components of the lipid panel that I want to go over. So the first one that you'll see is the total cholesterol. And that's basically the sum of all the cholesterol in your blood. And if you think about your arteries like a highway, it's basically all the total traffic on the highway, but it doesn't tell you the good cars versus the bad cars, right? So that's when we get some other data. The total cholesterol includes the LDL, which is our quote unquote bad cholesterol, the HDL, which is our good cholesterol, and also the VLDL. So typical values that we're looking for the normal range is less than 200. And then the LDL is basically, it's calculated. It's not actually measured. That's our bad cholesterol. And those are basically the cars that are dumping in the cholesterol into the artery wall, which is the main driver of plaque buildup, atherosclerosis. And this has a strong link to heart attacks, to stroke. And depending on, what your risk profile is, what your history is, typically our goal is less than 100. But if you have a history of heart attack, stroke, we tend to go with lower values. So that is tailored a little bit to the patient, but for the general population, less than 100. Then we have our good cholesterol, the HDL. And this is basically the cars that are taking away all of the bad cholesterol, all the cholesterol from the artery. And so it really helps remove cholesterol from the arteries. Typically greater than 60 is cardioprotective. So, people ask, how do we improve our HDL? Exercise is one of the things, but the caveat is, they've checked it, and really a higher level isn't always necessarily that good. So triglycerides are basically the fat in the bloodstream. And a high level is linked to metabolic syndrome and diabetes. And so our value that we're looking for triglycerides is less than 150. Then
I heard somebody say once, and I mean, obviously there's the genetic component of triglycerides too. So this isn't for everybody, but that a lot of times it can be one of the first pickups that people are kind of on their way to diabetes, right? Like even sometimes pre-diabetes, like before they realize that you can actually see it in those triglycerides starting to go up, which I thought was interesting. I didn't realize that before.
Yeah, so definitely all of these values are important to look at, and they all give us an insight into what's going on. So yeah, triglycerides is the one that really is that link to diabetes and metabolic syndrome. And one that's really important that a lot of people don't look at is the non-HDL. So the non-HDL is basically the number of all the particles in your blood that can cause plaque. So it's your LDL, the remnants, the very low, and the intermediate. So non-HDL is actually a very important number to look at. And in a way, it's like the cheap way of calculating an ApoB. And we're going to talk about ApoB next. But to calculate your non-HDL, which your lipid panel will show you, is your total cholesterol minus your HDL. So it's basically should be less than 130. And these are all the atherogenic particles in your blood. So very important number.
So you can get that then on just a generic cholesterol panel.
Correct. And usually they do report non-HDL, but that's a really important number. We want it less than 130. And so those are all the bad particles. Then the, sort of newer ones are ApoB, and that's also the number of atherogenic particles. So what we've realized is actually it's the number of particles that really causes the issues, right? So we want to know how many of these bad particles do we have in our bloodstream? And that's where we get our ApoB, which is essentially very similar to our non-HDL. And for the ApoB, we do want it less than 90. But again, there's different goals based on what your risk is.
Yeah.
But generally, less than 90 is optimal. And then there's...
Do they risk stratify that by like ages, or no, it's just kind of a general for everybody below 90? Okay.
General for everybody. But then if you have an elevated lipoprotein A, which is a genetically determined LDL-like particle, but it's extra sticky, it forms plaque way more at a younger age. And this is something that really everybody should have checked. And we're going to go into the new guidelines for lipids in a little bit. But basically, there's two different cutoffs depending on which unit you're using. So less than 30 for milligrams per deciliter and less than 75 for nanomoles per liter. So this is a really important particle because, again, it's extra sticky. It gets in those arteries. It forms clots in there too. It's prothrombotic. So this one's a nightmare. So lipoprotein A, a really important marker that everybody should really have checked.
Yeah. And you said that one's genetic. So is there
Correct.
a way to really decrease that as much, or not really? It's more than you have to try to decrease all the others.
So as of now, the trials are ongoing to test the medications to lower your lipoprotein A, and also to see what cutoff, how much do we really need to lower it by, 50%, 30% to make a clinical difference, right?
Yeah.
So right now, there's no medication to lower it, but what we're recommending is if you do have an elevated Lp(a), is to decrease your ApoB and your LDL. And that would be via exercise, diet. Generally, for most of our patients, we do recommend Mediterranean diet and exercise at least 150 minutes per week. And then if you're not meeting your goals of ApoB and LDL, then you might have to turn to medication like statins to help you lower your risk.
For the exercise, 150 minutes, is that like 150 minutes of walking? Is it weights? Is it a mix? Or what's the thought in terms of
moderate exercise, and it can be broken up, as much as you want. So 20 minutes here, 30 minutes here. Aerobic exercise, so moderate intensity aerobic exercise.
Okay.
Strength training also does have its benefits, but in terms of for cardiovascular, we're recommending the aerobic exercise.
Okay. So specifically for cardiovascular health.
Yeah.
Interesting. Okay. So I think, was there anything else in that?
Those are the main things in the lipid panel that you really want to look at.
Okay. So I think the next question, which kind of goes into the lipid panel, is I think most people get a standard cholesterol panel, right? So it has the LDL, the HDL, your triglycerides, but there's also this particle-based profile, which I think a lot of people are not quite as aware of. So what do you think, is that better for everyone? Is it just a certain population who needs that? And what does it include?
Right. So for the particles, so basically that test gives you the number of LDL particles as well as the size. So what we know is the small particles are worse. The small LDL particles are able to get into the arteries a lot easier than those fluffy, big LDL.
Okay.
So if you have a lot of small particles, that increases your risk. So who would I get this on? I would get this on patients that have a very significant family history of premature coronary artery disease.
Okay.
And those would be the main ones, or a really elevated Lp(a), just to get a more idea of what's going on with their LDL and what the numbers are.
Okay. No, that makes sense. So I think you were saying they came out with new guidelines because before, people didn't, you had to really ask for your ApoB, lipoprotein A. So how has this changed in the new guidelines? Is it kind of the same, or what's kind of the changes there?
Really excited about this new guideline that just came out this month, actually. So the timing of this podcast is perfect. And basically, to sum up, guidelines are saying every person should have an Lp(a) tested at least once in their lifetime. And you just need it once. It's genetic. It's not going to change.
Okay.
You basically just need it checked one time. So that's the first thing that's new with this new guideline. The second thing is they're talking about early screening as young as 9 years old. because plaque buildup really starts when they're toddlers.
Yeah.
And so early screening starting at age 9 for everybody.
Which is wild because then that's in the pediatric population. And for people to know who have kids, right, that they want to be asking for this. So interesting. So, I mean, your lipoprotein A really should be the same when you're 12 as it is, when you're 50.
Right.
Okay. Interesting.
Right. And what's interesting too, because I had mine checked recently and it was actually elevated. And as a cardiologist, that definitely didn't sit well with me, but it's genetic. So, but what's interesting is when you do have an LPA that's elevated, your kids should be checked as well.
Okay. I mean, so, that's good to know.
Age starting at early as 5 years old, you can check them, but I don't know who wants to, try and get blood from a 5-year-old, but you can wait till they're like, 9, 10, but they should be checked as well.
Yeah. Yeah, that's interesting. So, I think kind of it does help to have like real numbers, for people to kind of put in perspective. So I figured we'd talk about mine because, I mean, like you said, I went and got all this and then it scared me because I was like, I'm already exercising and being healthy and, it's so.
Right.
So I think, anyway, it'll give a little bit more practical application for listeners, though, kind of like hearing and seeing a profile. So my LDL was 113, but my particle number was 1,659. And then of that, because then we were talking about the small, medium particles. So the small LDL was 251. And then my medium was 311. My LDL pattern was A, which we didn't really talk about patterns. What do you think about patterns?
Patterns, the A class is kind of the higher risk category.
Yeah.
And so again, at this point, we don't really have anything that can lower these particle numbers or the LPA, but it's going to be mostly lifestyle modifications. And then if we're not reaching our goal for LDL, then, it would be a statin. Okay. So you have basically a lot of small particles and and a good number of them. And so these get into the arteries a lot easier. So it definitely increases your risk of plaque formation.
Yeah, which is what I was worried about. And then on top of that, my lipoprotein B was 91.
Yeah.
And my lipoprotein A, little a, was 90.
Right. So your ApoB was right at the border, right?
Yeah.
So less than 90 is what our goal is. So you're right at the border for ApoB. Your LDL is elevated and your lipoprotein A is elevated. So for you, the goal would be to get your ApoB less than 60 and your LDL less than 70.
Yeah.
And if you can't, tough, right? You're already doing all the good things. So, the next step may be to consider a statin to decrease your cardiovascular risk.
Yeah, I did like a deep dive on some of this stuff and like anything that I could be doing. And the only thing that really came up, and we'll see, I'm going to repeat my cholesterol panel, is I was using like the French press, which doesn't filter out like some of the oil particles. And there are like some things where it says that can maybe increase it. So I changed that. And I need to up because I've been doing more weights, right? But that isn't quite as much in terms of like the aerobic exercise, which kind of helps some more with the cardiovascular profile. So those are like kind of the interventions I'm doing now to see if that helps at all. But, we'll see. But I went and got, because of all of this, then I was like, well, I want to see how my arteries look. So I got what we call coronary calcium, a CAT scan to look at like the calcium that's in my heart arteries, which was good.
Right.
But, it doesn't, again, go into all of the softer plaque, which like you said, I don't know if you want to talk about that, but that's kind of the more dangerous plaque. So what do you think in terms of if somebody has these abnormal profiles, when they should get imaging or anything like that?
So we do have quite a lot of tools within cardiology. One of those is the calcium score. And basically this is a quick non-contrast CT, doesn't take very long at all. And they just measure your plaque burden in terms of the calcified plaque. So that's what it's looking at, calcified plaque. And so that's a good tool to use if you do have elevated lipoprotein A and you're seeing all these high-risk things. You can ask your physician to order the calcium score. But exactly, it doesn't pick up the soft plaque, the vulnerable plaque that maybe they're lingering, but as of now, if you don't have any symptoms, insurance doesn't cover the coronary CTA, and that's a full CAT scan with contrast that's looking for those soft plaques. So without symptoms, the best bet right now is a calcium score. And that basically gives us a score from 0, which is what we want, all the way up to thousands. And then based on that, we would decide what further testing we would need.
Where is like the cutoff in terms of when you would recommend somebody to go get that versus to like kind of wait and watch based on like their numbers, like their LDL numbers? Like how often is it where you're saying, hey, let's just do these modifications, come back in 3 months, we'll repeat your cholesterol panels? Like what's kind of your cutoff for that versus just going straight to it?
So it's also age dependent because it takes a while for calcium to build up in the coronaries. And so typically I don't recommend these calcium scores for anybody under the age of 35.
Okay.
So 35 for age is my cutoff. And then if they have elevated LPA, I would say to get the calcium score if they're above the age of 35.
Okay. All right. Yeah. That's good to know. And then, we went into it a little bit, but so the lipoprotein A, just so that, listeners understand, because it is confusing, all of these.
Yeah, it is.
So the lipoprotein A is what's genetic, really can't be changed, but it kind of is like a warning that, hey, you're at higher risk.
Right.
But you can a lot of times change your apolipoprotein B and the LDL.
Correct.
Okay.
And your triglycerides as a function of diet, and HDL to a certain extent as well.
Is there data on for your LDL and your apolipoprotein B, how much can be changed by diet versus exercise? Or is there not really much in terms of like stratifying those out? You just really need both.
No, there's no real data on that. But, we just do as much as we can with lifestyle modification to avoid having to start, medication. But sometimes you're going to need it because you're fighting genetics and there's only so much you can do.
Yeah. And I know you mentioned the Mediterranean diet. So that's something that you typically find is very helpful. Yeah.
So with regards to diet, that's the one we find is most sustainable, that has good data behind it. And that is really essentially limiting the red meat to once a week. Really no processed red meat. The processed, meats in general are basically carcinogen, same as smoking. So we really tell patients, please avoid those processed meats like hot dogs, cold cuts, all that sort of stuff. Obviously, fruits and vegetables. With fruits, we recommend a lot of the berries. It has a lot of antioxidants, especially blueberries. Nuts like walnuts, especially walnuts with blueberries together. That's a really good combo to help with decreasing the oxidation. Fish is important. We're okay with chicken and healthy fats, olive oil, avocado, stuff like that. So, that's what we're recommending, combined with the exercise, which we talked about the goals for that. That's just the two main things you can really work on that you have in your control.
Yeah. Which, I mean, it is nice that there are things that people can change, right? Diet and lifestyle wise that do have an effect, right? So,
right.
And then I think a lot of people talk about fish oils. How much do you find that those help? If somebody's on the Mediterranean diet and they're exercising, but things, still their numbers aren't optimal. Do you find that sometimes adding a fish oil helps or not really, or?
The data is not that great, so I don't routinely prescribe it for my patients.
Yeah.
So, rather I'll just tell them to just eat their fish. And as much as you can, try for the wild fish, not the farm fish, because there's just a lot of toxins there. But I don't routinely prescribe fish oil, no.
Okay. And then I'm curious, I feel like there's more coming out about like microplastics and like that affecting like cardiovascular health and everything. Do you find, I'm sure there's probably not data in terms of it affecting like LDL, but do you think microplastics are something people need to be aware of and worried about, or not really?
So there's an interesting study where they actually looked at the cadavers and they found microplastics in the coronaries. So, I mean, these microplastics are really everywhere now. And, at least we're in our home now, we've tried to replace as much as we can, especially for our kids who are young. We're really trying to avoid plastics because there's still so much we don't know, but we do know it's infiltrating everything in the body now.
Yeah.
So just as much as you can avoid plastic, the better.
Yeah. I know it's so wild how it's like everywhere now. Okay. I think that's the main stuff then for the lipid panel and the particle-based profile. I think kind of,
I do want to say something about statins in general, because there's some
that'd be great.
Some misconceptions and some negative connotations with that medication. But what the statins do is they basically stabilize the plaque.
Right.
So they turn those vulnerable plaques that are likely to rupture and cause a heart attack into these sort of thicker walled calcified plaque. So actually what's interesting is when you are statin, your calcium score does tend to go up a little bit, because now those soft plaques have turned into some hard plaque that's less likely to rupture. So it really decreases inflammation at the artery level, stabilizes the plaque, and decreases your risk of heart attack. And they've done a lot of studies to investigate the side effects, because a lot of people report muscle pain, when you're starting the statin. But I think, it's something that they've just heard that's a possibility. And, part of it is probably just from that. But they've done a lot of studies where they had people on a statin and they didn't, essentially tell them, and they had no symptoms at all. And then they were on a placebo and they were still having the same amount of muscle pain as the other group. So, the risk of actual myositis, inflammation of the muscle, causing issues is very, very, very low. So these statins are well tolerated. Based on our big studies, they really should not be increasing any pain in your muscles. And they're very, very beneficial.
Yeah. No, and I think, because I do think a lot of people are like, oh my goodness, now they've changed the recommendations, which I don't know if you want to talk about that in terms of like when the ages for screening and when they start now statins, depending on, your LDL levels and cholesterol and everything. And I think some people are like, well, that's really young, but it's also like, it's much better to prevent a heart attack again than to have to treat a heart attack and to prevent all of this.
Right.
And I know a lot of people do talk about the side effects. Do you find I think the data is very mixed on CoQ10 or anything like that to give in terms of
I do.
The muscle stuff? You do give it? Yeah. Okay. And
I do, because I think there's been some good success when I've given it to patients. And so, and there's really no side effects with it. So if they are complaining of having muscle pain, then I will prescribe that. And I'll tell them, you can take your statin every other day, start taking it every other day, see how you're doing.
Yeah.
You can take coenzyme Q10 and let's see how we're doing.
Yeah.
But I usually will start at the lowest dose and work up from there.
Yeah.
Yeah.
How much in terms of, because I do find it interesting. I think there's like this side effect of statins where they can kind of increase your insulin resistance slightly, but overall they're still so effective in terms of cardiovascular prevention. Do you see that a lot or not a ton? Yeah.
No.
Yeah. It's just an interesting, I don't know, thing how it works, but yeah, we do have a lot of data on it. It does help a lot of people. And I think a lot of people are not aware of how it stabilizes plaque, and that the vulnerable plaque is really the issue. Right. And so,
so what they found is, the plaques that rupture causing heart attacks are actually those moderate lesions, those 40-50% lesions that rupture because it's a vulnerable plaque. And so the statins really help stabilize, calcify, thicken those plaques so that they don't rupture.
Yeah, break off and then cause that acute blockage. Yep.
Right.
Cool. Awesome. Let's see. We talked a little bit about blood pressure. I didn't know if you wanted to go into that a little bit more in terms of why it's so important for prevention and everything.
Right. So, blood pressure, is just basically high blood pressure puts an injury to the walls of the arteries. And anytime there's, either a mechanical insult to the artery wall, inflammation from something else, the plaque is just going to accelerate. So high blood pressure is one of those things that is, accelerating plaque because of the increased pressure in the artery walls. So having that under control is a huge, huge benefit and decreases your risk of heart attack and stroke.
Yeah. Yeah. Blood pressure's control is so important. And I think a lot of times people don't realize, again, like we talked about earlier, that they're walking around with high blood pressure because they're not checking it. But now it's so easy to get those, home blood pressure cuffs so that people can actually check and make sure that they're in the normal level and everything. And there's so many treatments for it, not just, and again, a lot of times, like what we talked about, diet and exercise are going to be your number one treatment for that anyway, because a lot of times if people are exercising, having the right diet, if they've been overweight, lose some weight, a lot of times that in and of itself will help control the blood pressure.
Right. And, I really try and do the least amount of medicine possible. So if the patient's starting to lose weight, we're able to slowly taper it off. So I tell them this isn't forever, we're putting these meds on now, but if we're able to lose weight, able to do all these things, then we can come off of some of these medications. And I really have taken patients off a lot of their blood pressure meds because they've been doing really well with that lifestyle modification.
Yeah. And I think that that's like also something to like remind people of like this, there are a lot of things that you can do in terms of adjusting these risks that are, non-medications. And that is the goal, right? Is to actually make these lifestyle changes. It's just, it is hard. Right. And so, it does take work, right. To do all the exercise and to eat healthy but it's very doable and it can have huge effects, right. In terms of not being on the medicine. So.
Yeah. And really getting all these things checked does motivate you. So when I got my Lp(a) checked and it was elevated, it really motivated me to do a lot better, because I would indulge in the cookie here and there, obviously. But now it's like I'm turning to healthier options, even though my baseline was pretty good, but there's always room for improvement. And so it really, motivates you to do better. And so that in itself, is a good reason to get it checked.
Yeah, no, I agree. And then again, it's like you can do these lifestyle changes and then you can follow up and you can see how it's changed, and then if you still, even with everything else, are still in that, increased risk, then that's where at least there's medications. And there are other options in terms of still, helping with prevention, which I think is so important.
Right.
So I think, which we didn't even mention smoking, but I think it's just probably because it's a given that smoking is very bad for heart health.
Right. So there's what the AHA, American Heart Association, has their essential 8, which are basically all the things that you should do to decrease your risk of heart disease. And, smoking cessation is obviously on there, as is exercise, diet, sleep, which I think we're going to get to here soon.
Yeah.
So, they have also a calculator there where you can kind of plug in all this stuff and see where you're at. The other calculator that now, based on the new guidelines, is coming into favor more is the Prevent Risk Calculator. So that's available online. You can just plug in your information and it gives you your risk of basically heart disease.
Oh, that's cool. Mm-hmm. All right. Prevent Risk Calculator. Oh, Prevent Risk. Okay. All right, cool. So that's good for people to know. So I think, let's talk about sleep then. How would you say sleep ties into heart health?
Yeah, so it is one of the essential 8 from the AHA. Their recommendation is 7 to 9 hours of sleep a night.
Wow, 7 to 9.
So what happens?
People aren't hitting that.
No, for multiple reasons.
Yeah.
I have, 2 little ones and 3.5 and 1.5. So for a long time, the sleep was really broken up, right?
Yeah. Not to mention when you did fellowship, and then before that, when we did residency.
Yeah. So it hasn't been great for a long time. But basically what happens when you don't get enough sleep, your body increases its sympathetic drive. So you have a sympathetic, parasympathetic system. Sympathetics like the fight or flight and causes blood pressure to go up and heart rate. And so when you don't get enough sleep, that system takes over and that'll increase your blood pressure. So one way to really help with blood pressure is to get good sleep.
Yeah.
The other thing is decreased sleep increases the inflammatory cytokines in your body. So interleukin 6, TNF alpha, all these things. And really inflammation is one of the main drivers of any chronic disease.
Yeah.
So minimizing inflammation in the body is really the goal. And so decreasing those inflammatory markers by sleeping well is really what you want to aim for. So yeah, 7 to 9 hours is the recommendation to decrease cardiovascular risk.
Yeah. And I guess, we probably should have talked about it in, the cholesterol panel and everything, but the inflammatory markers like CRP that you mentioned, IL-6, when would you say patients should get that checked? Would you
I would say everybody should get a CRP, honestly.
Yeah.
I don't routinely check the other ones like IL-6 and TNF alpha. But I do check CRP in everybody just to get a baseline, kind of see where their inflammation is and what's going on. So everybody should get that checked as well.
Yeah. Because I do think, like you said, like inflammation, we do know it is very, again, higher risk in terms of cardiovascular disease, higher risk for pretty much autoimmune diseases, cancers, like everything. It's like inflammation. Yeah, really, dementia. So overall decreasing your inflammation burden is so important. So I think it's very helpful because the hard part is it's not specific. It doesn't say, hey, this is what's going on, but it does show that, hey, there is increased inflammation. And so then you can try to decrease your inflammatory burden, and try to decrease that as much as possible, which is important. So
exactly.
Okay. So sleep, super important, which we know. That's why at Duration Wellness, it's one of our focuses. So I had a study here that I thought maybe we could talk about a little bit that I thought was interesting, and it'll be linked in the bottom of the podcast. But basically it was looking at like insomnia symptoms and cardiovascular disease. And it was a longer study, a cohort study. So again, sleep studies are kind of hard because you can't say, hey, you're sleeping and you're not, right? And it can't be what we call double blinded, where people don't know if they're sleeping well or not sleeping well. So that is a hard part about sleep studies, is you can't quite do that. But I just thought maybe we would talk about it a little bit. I don't know if you had a chance to look at it. But what I liked about it is that it kind of went over cardiovascular disease over 10 years. So a pretty significant amount of time. And it also had a pretty large amount of patients in it, right? So there were over 45,000 people that were recruited into it to kind of look at their sleep, basically. And they used a questionnaire to kind of gauge, how well they slept. And, to put it as simply as possible, the worse their sleep was, it was correlated with a higher risk of cardiovascular disease, which I thought was interesting too. So, if you have your sleep is not ideal, but it's not horrible, you have a little bit increased risk, but as your sleep gets worse, it really was associated with a higher risk. I don't know what you thought about it in terms of the study. Anything?
Yeah, I thought, when we're looking at studies, there's a few things that we look at to make sure it's an appropriate study. And I think number of patients is a big one. Like you talked about, there's inherent flaws in these type of studies, but it was a lot of patients. And I think it was a relatively well done study, and, just confirms what we know about decreased sleep and the cardiovascular risk. So super important. And, one thing I also started doing, because I'm about to be 40 this year, and I think that was a big wake up call. I was like, oh my gosh, I'm about to be 40. Let's make sure we're getting this together. I have 2 little kids. I want to make sure, I'm healthy for them too. Is I got one of the wearables, and, there's a ton of different wearables out there right now, but I think, they just give you so much valuable information, especially for sleep. So, it tells you your sleep efficiency, which is a huge thing. So sleep efficiency, it tells you how much deep sleep, REM, when you're awake, and, you can kind of see what some of the lifestyle choices you make, how it affects some of these sleep things. So I'm a big, big fan of these wearables that they have out now for the sleep data, for recovery, for strain. Mine does EKGs, blood pressure, and it helps track your menstrual cycle stuff and your hormones. And, part of this is where I got all those biomarkers. So there's a lot of good tools out there right now. And I think these wearables really have a good part in prevention. And so, the data you get for sleep on there is just amazing. So
well, and especially, when they're saying that you need 7 to 9 hours, I think a lot of times people don't quite know where to start. And so I think, that's why I have a wearable too, is then I can actually have, hey, last night I ate a little bit later and my deep sleep was way worse.
Right.
I had a glass of wine and I can see that my sleep was trash. Or, you know, I did the sauna and I slept way better, right? Like these things that are kind of like, you don't always like feel it the next day. And so I think it's really helpful to also have the data there to be like, wait, that really did have a big effect. Right. So,
or I worked out too late, you know, and it gives you a lot of good information for you to help target your lifestyle choices, really.
Yeah. I will say something in this study that I found was a little bit interesting, and I would be curious to see if the other sleep studies in terms of cardiovascular risk teased them out. And I don't think that they do, is if like sleep apnea is a big driver for a lot of it. Because like some of the people who had like a higher risk were people who it seemed like they would be a higher risk for sleep apnea too.
Right. So sleep apnea is huge in the cardiovascular world for sure.
Yeah.
And it does decrease your sleep efficiency, obviously, because you're having these episodes of apnea, and sleep apnea affects blood pressure, causes your blood pressure to go up, causes heart rhythm issues, causes a strain on the right side of the heart, can lead to heart failure, pulmonary hypertension, really affects so many things in the body. And so, you know, that's a really important thing. So if you're, you know, being told that you snore, you have episodes where you stop breathing, if you have a really large neck circumference and that, you know, overweight, and you wake up, you don't feel good, you fall asleep easily, these are signs that you could have sleep apnea, and you should ask your doctor to order a sleep study, because sleep apnea really has a big toll on the heart for multiple reasons.
No, it does. And I think, you know, people used to, because like the diagnosis, you used to have to go into a sleep lab and people would watch you and people hated that. But now there's so many, a lot of times they can even do it from your home. And so I think people haven't realized how that's changed, you know, now where it's a lot easier to get tested and not having to go into a sleep lab and everything. So,
and even the treatment, like the actual masks and stuff have also changed. You know, there's a lot that aren't these big chunky masks that go over your whole face. There's some now that just look like just, you know, the nasal cannula for oxygen. They're really small. So there's a lot more options now for treatment as well that are a little bit more streamlined and not so bulky. So
yeah, which is cool. And then I think we touched on it a little bit, you know, in terms of sleep, when people are sleeping less, how it affects, you know, blood pressure. So blood pressure can go up. So that's like a big part of blood pressure control. Have they had any associations in terms of cholesterol and LDL? There's not really studies on that, right?
No, I haven't seen any.
Yeah, I hadn't seen any either. I'd be curious about that though, because again, you know, not having enough sleep does affect inflammation. So, you know, it does have an effect on all of the inflammatory markers. So.
Yeah. And when my patients are telling me they can't sleep, one of the first things I go to, you check their sleep hygiene, right? Like, are they using their screens, which now a lot of people are, you know, laying in bed on their phone, quote unquote, doom scrolling, and, you know, they're on their devices. So we go through sleep hygiene. I spend a few minutes and kind of see if I can figure out what they're doing that is not great. And then there is a role for supplements. So magnesium definitely is something I prescribe, honestly, to all my patients for multiple reasons. One is for sleep. Two is for heart rhythm stabilization. Patients that are having, you know, these early beats from the bottom chamber, we call PVCs. Before going to our other prescription drugs, I go for magnesium, especially in our young patients. I go for magnesium. And most people are deficient in it anyways. So there is a big role for supplements tying into cardiovascular health, and, you know, just immune function. Vitamin D is another huge thing. So there's a big role for all these things. And so when you look at your labs as a whole, part of it should be your vitamin levels and trying to tie in everything together to just optimize your health. And supplements play a big role in that.
Yeah. I mean, that's like actually one of the other things that I got checked was my magnesium level and the red blood cells, actually, so that I could see like what my true level was at. And I was low, even though I supplement with it and I have a healthy diet, which is kind of crazy. So, I mean, there's all these genetic factors too, I'm sure, but do you have a specific type of magnesium, like magnesium glycine, citrate? What's your usual like type? Because there's so many different magnesiums.
My go-to is usually glycinate.
Mm-hmm.
So that's the one I usually prescribe. Usually for me, I'm telling them 200 milligrams twice a day and can go up to 400 twice a day.
Yeah. And that's also what will help a lot of people with sleep too. Like that's what I mean is in our sleep club is magnesium glycinate. I think there's like a lot of good data in terms of its absorption level and helpfulness and everything. So yeah. That's awesome. Okay. Well, I think that's pretty much everything. Anything else that you can think of? Do you want to mention?
I think now in today's world, the more information you have is just the better for longevity, So get your labs checked, get a wearable. If you're able to afford a wearable, go ahead and get one. There's so many different kinds. Just make sure the one you get, you can track your sleep and that'll be really beneficial. So get a wearable, get your data. Find a good, primary care that can tie this all in together, but be an advocate for yourself. You have all this information, be an advocate, just try and get the healthy lifestyle as much as you can to decrease your risk. Just get that information and see what your risk profile is. Yeah.
Yeah. I think that's awesome. Excellent advice. And I think there was a lot of practical and useful information for everybody. So now that they have the information, they have the tools that they need to ask for this and kind of, take their health in their own hands, which is great. That's what we want. Yep. So yeah. Well, thank you so much. This was awesome.
Thank you. It was a pleasure.
Yeah. And for everybody listening, another fun episode at the Duration Wellness Show. And we'll have more soon. All right.
Thank you for joining us for the Duration Wellness Show. We hope you feel equipped to apply today's science-backed insights to your daily life. To find show notes, past episodes, and all the resources we mentioned, visit us at durationwellness.com. As always, this podcast is for informational and educational purposes only and does not constitute medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The views and opinions expressed by guests are their own and do not necessarily reflect those of the host. We'll see you next time, and as always, we're here with you for the duration.